while climate change affects every region of the world, some regions are incrementally more affected than others. So when we look at equity, it's necessary that as a global community, we must look at our weakest link. Because unfortunately, whatever happens in one region, indirectly or directly will affect all the other regions ultimately. Take for example, the recent mpox outbreak started in DRC, but we can see the impact it has had, not just in the continent, but at some point it moved beyond continent. The same thing happened with Ebola and all of that. So what it simply points out is that as a global community, we must be intentional about looking at our most vulnerable population and the weakest link in building global resilience and equity. So I want to highlight here that climate change does not just present a risk now, it also presents futuristic risk. And we've seen this with a lot of projections, whether from the WHO in terms of the expected additional deaths that climate change is going to be causing from 2030 upward, almost 250,000 every other year. Or we're looking at the expenditure in terms of the socioeconomic impact, where it is already estimated that it's going to add an additional cost of over 2 to 4 billion per year starting from 2030. But contextualizing it within Africa, we are most impacted, and yet we contribute the least in terms of global gas emissions that drive climate change. Suffice to say that in Africa, of the over 2,000 public health events that occurred over 2 decades, 56% of them are linked to climate change. And also, 7 in every in the 10 countries that are most vulnerable to climate change issues, 7 of them are in Africa. And that is why, when we're looking at equity, a lot of focus should be in Africa from the global community. This just shows a vulnerability map across all the regions of the world. You can see where the darkest shades are, and the spread in terms of geographical scope. Almost every part of Africa is shaded, and some countries are significantly more vulnerable than the others. Now, every year, about 12 million deaths occur as a result of environmentally leaked risk factors. Of those 12 million, 2.2 million are in Africa. Now, when you break down the 10 causes, the 10 most important contributors of death, you find out that infectious diseases, which lies at 7, 8, 9, and 10, is usually what drives the death in Africa. And when we try to narrow it down, you see that things like malaria, yellow fever, dengue fever, cholera are driving significant impacts. And that is why most vulnerable populations, which are also at greatest risk of climate emergency impacts, are also the same people who suffer the greatest brunt of these infectious diseases. And so we need to reach out to them. And also say that we have with 25% more climate-related events between 2011 and 2021 as compared to previous decade. So what we're seeing is an incremental impact. And there's a lot of other goals that have been set around 2030. Whether you're looking at the cholera elimination goal or you're looking at the SDGs, you find that climate change has a lot of impact across all of the 2030 goals. And so it's important that it becomes an issue that we all look at. Now, I tried to bring some highlight in terms of the linkage. Why I brought this is because I expected that this is going to be a multi-sectorial and multidisciplinary team. And in the morning, we saw people from the architectural field and all of that. Somebody has once asked me in Zimbabwe, what is the link between climate change and health? And I felt that this was necessary to highlight. Now, of course, for those of us who are in the health sector or who are epidemiologists, there are 3 triads for any time that an infectious disease needs to occur. And those 3 triads are the agent, the host, and the environment. Now, the greatest thing is that climate change affects all of this. By nature, any impact or any threat that has the probability of tilting any of these apexes of this triangle has the probability of exacerbating impact. But climate change can affect all of them. Either the agent to make them more virulent or to expand their geospatial distribution, or the hosts. Heat stress can even predispose many of the hosts to infectious diseases. And we've seen this also in many circumstances. Or the environment. Climate change continues to modify them. In Kenya, for example, We're already seeing malaria in heater to malaria-free zone. And when we check, we find out that the ambient temperatures in those areas are increasing significantly. We've also seen where flood drive the dynamics around waterborne diseases. So that's why at CDC, one of the things we're trying to, because we have a vision of a healthier, safer, and more prosperous Africa. And I think one of our speakers today, earlier today, had talked about the economic impact of climate change. And what we understand is that you cannot be prosperous if you are consistently battling diseases. We cannot achieve the SDGs if we are consistently investing in responding to infectious diseases, because finances that would have been used to develop will be used to contain diseases. And then the workforce that is supposed to work, man hours are lost significantly. And all of these are actually has socioeconomic implications. So recognizing this at Africa CDC, we felt that we cannot achieve this vision of a safer, healthier, more prosperous Africa without investing in climate change, without investing in climate action. But that investment needs to be coordinated, it needs to be unified, there needs to be synergies for us to be able to optimize investment. And what we've seen is a lot of siloed approaches. Little drops here, little drops here. They say little drops make an ocean, not when those drops are scattered. They must aggregate at a certain point, isn't it, for there to be an ocean? And that is what we need to begin to think around, especially for all of us making one significant investment, either in terms of human resource or whether it's in terms of direct investment. So they must speak to something that is coordinated and unified so that we can have incremental impact rather than disconnected impact. And that's why at Africa CDC, we developed a strategic framework that is looking over the next 5 years. What should we focus on as Africa? And what are the strategic interventions that should drive our actions, investment, and impact drive? And so we defined, I think this is just the link to that strategic framework, but suffice to say that the strategic framework was developed with member states of the continent, with strategic partners, and we followed through a roadmap that started at the first African Climate Summit at the sideline of that and accumulated into the launch just recently in July. This, now we're looking at what do we focus on. There are a lot of vulnerabilities that Africa is exposed to, and Africa's vulnerability has implications for the world. And these vulnerabilities are mostly infectious in nature, you know, and many of them are also diseases of poverty. So what it does mean from our thematic focus is that we cannot do equity or think of equity without thinking of these diseases. You're looking at waterborne and zoonotic diseases, vector-borne and zoonotic diseases, food nutrition insecurity, and heat waves, and extreme temperatures. And I'm sure there's going to be a session on that too. Now, but we did not just arbitrarily decide that these are the vulnerabilities to focus on. We took a very lengthy process, bringing experts, and we used some basic criteria, and these were the 5 vulnerabilities that came out clearly as the what's for us to focus. Now that we've identified the what, how do we address this? We feel that we should adopt a One Health approach. And that is why I was discussing with somebody at the back. I said, this is what I love about this G-STIC conference. I think this is one very good platform for us to be able to integrate our ideas. I see cross-sectors being able to cross-pollinate ideas and then be able to do things cooperatively. And that is one thing we need to do for health. Okay? And we need to bring the environment, we need to bring the animal health sector, we need to bring the human health sector, we need to bring the finance, because sometimes they make all of the decisions that drive whatever we do. But I see us working sometimes in silos, and the finance people don't understand our language. They don't even know why health actions should be linked to climate, because, and that disconnect is making that sector to be poorly funded in terms of climate actions that impact health. And that needs to really change. So we came out with 6 strategic intervention pillars, ranging, of course, from research and innovation and data, which is a critical gap in Africa. Recently, I was looking at the intersection between mental health and climate change, and somebody did a systematic review of over 3,000 articles. And do you know what happened? What was reported in Africa? 0, no publication showing the intersection between climate change and mental health. Perhaps there might have been some studies, but it's not documented anywhere, or it's not documented in repositories where we can easily have access to it. So how do you make decisions at that nexus? But we do know that for every climate emergency, people are significantly affected mentally. When people are displaced, it's never comfortable. And we also know that that is also driving conflicts in many areas. Because when you have drought, sometimes a whole community migrates, and then you see communal clashes because there's land encroachment, and these people must survive, so they move to where the ground is green. Capacity building, I'm sure a colleague, one of us will speak to that. Risk communication and community engagement. Somebody did talk today intensively about the community. No matter what global partnership we reach, no matter what policies, no matter how beautiful they are, if they do not get to the most vulnerable communities where impact is expected, then we've not really done much. And so this should be the thinking as we discuss all of this. Governance and leadership, we're trying to see how we can get health integrated into the NDCs. Many countries are already revising their NDCs, but many have not actually factored in health as an integral component where there are actionable items that are pursued as part of the overall goals of those NDCs. We're pushing that, and we're trying to get this to the attention of the highest decision makers in each of the member states. And suffice to say that Africa CDC will enjoy the political will of the 55 member states, heads of states of government in Africa, because we are the health agency of the African Union. So that gives us some leverage in being able to drive some of these strategic interventions at that level. Then beyond all of this is innovative financing. Today, I think when we had earlier discussion, our colleague that presented on this CSIR had talked about the innovations they are doing. One thing I've come to realize, resilience can never be built on goodwill alone. No matter how much you want to get help, nobody can help you to the extent you can help yourself. So we must also look at what are indigenously available for other people to support. Goodwill can never build resilience in any country alone. And so we need to move and think about how do we develop strategic funding. So all of these I've already discussed. I will not take time because of our time to go through all of this, but just suffice to note that we have also further broken down all of these strategic thematic areas into clear actionable items that can be directly invested upon and that can be directly implemented and tracked, okay, across all of those. But suffice to also highlight public health emergency and disaster response. A lot of climate-induced emergencies occur in Africa. Populations at the fringes are usually most involved. I was discussing with someone and I was giving a clear practical experience. We got support from the US CDC, WHO, and all of that to do a measles campaign, measles supplementary immunization when I was in Nigeria. And I was leading a state. A state is like a province here in South Africa. And we did very good plans. We wanted 95% coverage. We were supposed to start implementation on a Saturday, and on a Friday, it rained heavily, and there was flooding. Communities that we've already mapped, especially at the River Benue Niger intersection, were washed off. We couldn't reach them. Practically like 3-6 months after that campaign, there was an outbreak of measles in the same location. So you see, all that investment could not achieve, and it looked like it, just because the health sector did not look at the meteorological projections for those periods to know that it's going to rain, and we plan around those. So those are just very practical things. I want to end up with this. The framework has been launched. What we've been doing is to see how we can now facilitate adaptation at member state level, and also adaptation and buy-in from stakeholders that invest in this sector. So, and we've been doing that. One of the things we've started doing is building strategic capacities, because we found out that the health sector, who is supposed to action these things, have significant gap in terms of knowledge. And I'm sure this will be highlighted in the course of this discussion. But we're also mobilizing local and partnership support to be able to drive implementation. So I want to call all of you to please take time to look at this strategic framework, even as we try to frame our investment and support around innovation, around science, to see how do we work within the context of a well-coordinated, unified approach. Thank you for your attention.
Charles. Thank you, Dr. Charles. A very nice presentation about the CDC, Africa CDC strategy framework to attend health surveillance in front of climate change. It's very nice. And as we saw in your presentation, one of the main pillars is related with capacity building. Yeah, that's it. So I try to link to our next presenter, next speaker, Dr. Daniele Magalhães. Okay, Dr. Daniele, let me see, is a Senior Project Director of Global Consortium on Climate and Health Education from Columbia University in the United States, where she oversees global training initiatives and partnership strategies. She's an environmental health scientist from Brazil. She specializes in global health, sustainable development, climate change, biodiversity, and toxicology. Please, Dr. Daniele, the floor is yours.
Hello, everybody. Good afternoon to all of you, and thank you so much for the audience that's still here. I work, let's wait a little bit. So I work with Columbia University, providing capacity building and training to health professionals globally. And I will tell a little bit what we are doing, specifically in Africa, and Dr. Charles and Osman here has a specific role on this as well. And I'm very glad to share with you such a different perspective to see how we not only need science, technology, and innovation, but we also need to build the capacity of, in this case, health professionals to understand it, to identify the effects of climate change on health so they can be able to better respond and save lives. So, and this is my fourth G-STIC. I'm also a researcher at Fiocruz, and together with Paulo Gadelha, we coordinate the health program in G-STIC. So let's start.
The other arrow.
Yay.
So this is forward. This is forward. This.
This?
Yeah.
Oh, okay. It's back. Okay. So I'm going to talk a little bit about the consortium. The consortium was created in 2017, right close to the Paris Agreement, where 60 universities in US came together and decided that they need to provide a differential education for their health professionals, for their doctors, nurses, public health, and many others. And then they create this consortium that was hosted and still hosted by Columbia University. And we start with 60 members, and now we are 400 members of academic institutions in more than 69 countries around the world. And together, all these institutions pledge that the commitment to provide climate education to their students. So we estimate that together we are reaching around 250,000 students per year. And our goal by 2030, we want to achieve 800 academic institutions committed and offering climate change education in their academic institutions, and we are working for that. We are providing capacity building for faculty so they can be able to incorporate climate change in their curriculum. And we also do a global survey, which is part of the Lancet Countdown, to understand how these schools are not only incorporating or not, but also the degree of expertise and competencies that they are offering to their students. So our mission is to ensure that all health professionals throughout the world have the knowledge and the skills to identify, prevent, reduce, and respond to the health impacts of climate change reducing the health disparities, and improving quality of health and well-being. So to guide all our actions, we divide this concept, the core concept for health professionals, that includes all the necessary needs and learns that they need to have to understand the impact of climate change. So this framework is developed together with experts from the whole world, and it's updated every 2 years so we can have the most recent science adapt to this framework. And we have 5 domains: knowledge and analytical skills, communication and collaboration, policy, advocacy, and professional practice, public health and practice, more focus on the public health professionals, and clinical practice, more focus on the clinical, the doctors, the nurses, and with this concept, we develop curriculum, we develop trainings, and we have been training people all around the world. And we are now a collaborator center of the WHO. So we are pretty much providing education to all the regionals that WHO exists. And we did this in the Americas, and with a specific course in the Caribbean, the Latin America, the North America, Europe, West Pacific, Southeast Asia, and last year we start our journey here in Africa. So Africa has a lot of challenges, and that's why it's so unique in terms of bringing these projects to here. According to the WHO, it's estimating that between 2030 and 2050, climate change could cause approximately 250,000 additional deaths. But if we look at the results in the couple of years ago in Africa, we can see that probably this number will be very, very higher than that. Because only in Africa in 2023, the Libya's floods kills 11,000 people, and the cyclone Fred caused 860 deaths. The floods in the Democratic Republic of Congo also killed 3,000 people, so 15,700 deaths in 2023. And we also associate with extreme weather and events and mortality. And we also had mortality related to heat, approximately 28,000 deaths annually in Africa. And if we put all these numbers together, we will reach and I'm not even putting all the examples here, and we pretty much came close to 40,000 deaths in these few years that we passed. So it's a huge impact in Africa, and additionally, many countries struggle with insufficient health workforce numbers, uneven access to healthcare, and limited infrastructure, all of which reduce the ability to adapt and respond to climate-related health emergencies. And that's why we are here together with Africa CDC and many other partners to improve the capacity of the health workforce to respond to climate change and health. So these were our partners. We partner with the Association of Schools of Public Health in Africa, ASFA, the Africa CDC, the WHO Afro, the IMFI Africa Network, the Project ECHO, the Climate and Health for Africa Network for Collaboration and Engagement, the CHANCE Network, the Africa Research and Impact Network, and the Africa Population and Health Research Center. So together with all these partners, we developed our trainings here, and that I'm going to show to you the results. So this is a basic curriculum. We call this the Climate and Health Responder Scores. And we have this course in all the regions of the world that I show it to you. So we have the Africa Climate and Health Responder Scores. And basically, it's a course that has around 10 sessions. 10 sessions, this one have 11 with 90 minutes, 1 hour and a half, where we invite experts from the region and case studies from the region to contextualize all these topics that is showing here. And it's an online course, it's free of charge, and people can have certificate at the end if they watch 70% of the sessions and also score 70% or more in the final exam. So we received for this course 7,000 registrants, and this map shows the amount of participants for each country. The big circle is related to the registrant, and the smaller circle inside is the people who completed the course. So we started with 7,000, and then we finished with 1,600, a little bit more. These people was from 35 different health-related professionals: public health, environmental health, doctors, nurses, psychiatrists, nutritionists, people from the government, a lot of people from the government I'm going to show you. And they came from 47 countries of Africa, and 31% was working for the government, 27% for NGOs, 25% for academic institutions and other institutions. And what is really interesting in all this course that we do all around the world is we always ask if these people receive some kind of education or training in climate change before. And what is interesting is almost like 100% of the time, more than 60%, and I can tell sometimes 70%, 80% never received any type of education on climate and health. So in this case, 66% never received any type of education, and we saw that 64% of this was health professionals. And health professional was less likely to receive climate education because they are already in the field, and its students are more prone to receive this type of education in their schools. And again, most of these people came from government, NGOs, and then academia and private sector. And so after the course, we evaluate several skills that they learn and they gain during this course. And we observe an increase in 22% of the climate and health awareness. We ask them if climate change is important to their work. So, and they have to choose a number in a range between 1 and 10, and then we calculate these changes. And also in communication, how they feel confident to communicate with patients and colleagues, and we saw an improvement in 40%. How they feel prepared to work in adaptation and mitigation, we saw an improvement in 37%. And how they feel responsible to work on the adaptation and to help their health system to adapt and to mitigate, it was improved in 21%. And after that, after this big training, we thought that we need to continue. This is not enough. We need to make sure that Africa has spots where climate and health education will be offered in a sustainable way. So we create this second training. It calls Africa Climate and Health Educators Training, where we invite all those people who passed in the first training to apply and have a project related to how they want to teach people and how many people that they want to teach, where are they from, and they are professionals, they are professional, and then we selected 53 participants representing 25 countries in Africa. All of them committed to train health professionals, frontline workers, and students. And when we did the selections, we make sure to pick people from many different countries in Africa as possible. So these people passed through 15 sessions, pretty focused on climate and health linkages, curriculum development, measuring and monitoring impact, and teaching skills. This training followed the Project ECHO model, was in partnership with Project ECHO, where all these participants also share their experience, and we talk and we discuss together and we find solutions together. So at the end, 33 participants complete the course. They are from 15 countries, and they all receive a small grant of $1,000 to help them to start the implementation of this training. So we are in this stage 5. We are working in the stage 6. We are in the stage 4. We are working to this stage 5, where they are going to start to implement this course. And according to their prediction, we think that we are going to train 400 health professionals in person and with a local, very focused aspect on climate and health. So by the end, we aim to expand the impact of this training and capacity building across Africa. So just to finalize my presentation, without skilled health workers, climate adaptation plans remain aspirational rather than actionable solutions. This is very powerful, and I think this is something that you have to keep in mind. We talk a lot about science, technology, innovation, and this is super important, and that's the way that we are going to overcome this crisis. But we also need people capable to understand and to interpret all the necessary message that comes from this technology. If we think, I remember when we start this project in Africa, we knock on some funders' door, and they were working with capacity building, and we said, well, we are with this project. You want to help us to develop this training? And they said, no, we don't do that. What we are interested in is to build the capacity on research and technology. And I asked them, so how you are supposed to respond only with research and technology if we develop our early warning system and it says we will have a flood in 7 days? What people are going to do if they don't have the skills, if they don't know what is going to be the impact, what is going to be the medications that they are going to use, the medication they are going to use after, the roads that will take people to the health facilities. So there is a lot of things that need to be built, and we will only be able to build these paths and then this adaptation plan if we have the health workforce with the capacity and the skills to do it. Oh, sorry. Oh, no. Okay, so finish. Thank you.
I I think that we're gonna, at the end, we're gonna have space for everybody to, I hope so. So, Dr. Daniele, thanks a lot for your presentation. It's very important, as you mentioned, not only to train the health professionals, but to know how to communicate with the people that are really at the point, really the end user of the information, let me say like that. And it's very important, and to pass this information, it's important that you have this information acquired, monitored, and forecasted in that region. So I try to do a link for our next speaker, Dr. Osmani Ndai, from the Director General of African Center of Meteorological Application for Development. Dr. Osmani Ndai is the Director General of African Center of Meteorological Application and Development. Prior to that, he was leading Senegalese Meteorological Service. He has interest in climate prediction and its application in a broad sense, user engagement and ownership, tailoring climate information, private partnership communication. He has worked many years with partners like NGOs, research institutions, extension service, and users on how to deliver climate information services to the last mile. He's a contributing author to the 6th IPCC report, Working Group Number 1. He's a board member of the Global Heat Health Information Network, the Rockefeller Foundation's Expert Advisors Group, and Subseasonal Applications for Agriculture and Environmental SAG Group Health Desk Team. So please, Dr. Osmani, floor is yours. Thanks for your
Thanks very much, and thanks for having me here. So, how it works? This way. Somebody is like, oh, this one.
It's okay. It's this one, and then to pass, you need to, it's the below.
Okay, good.
And then it can go on.
Okay, to save this time. Thank you, thanks very much. So just a presentation or publication of where we are. ACMAD is an African center created by African countries to respond to climate challenges. And we are working at the continental level, and we are the regional climate center of WMO. So we do really services and want to help countries. I will start with this, because I'm going to talk about heat health, and it will be a big problem in the future. This is a report actually on 1.5 degree world, if you want, of climate change. And you look at the maximum temperatures that we can have, and you can look at here over the world, and you see that Africa is really a hot spot, you know, on temperature. So it's something going to be happening in the future, and we need somehow to deal with it. And this is a very strong message from IPCC. And if you zoom, you can see very clearly of Africa, and Senegal is the westmost one, is one of the countries we are really on the spot, and we need to deal with this. So how do we do that in Senegal? I was back then working at the Met Services, and we know that climate information alone is not enough. You need really to work with the communities in one to ensure that the problem we are trying to tackle respond, you know, very well with the need of the user. You are really human centralized, and you need also to ask other communities also working with you. So what we did is at the climate service, we produce a forecast as all climate services from 1 to 3 weeks, depending on NOAA forecast, long-range forecast. And from there, we compute what we call heat wave, you know, depending on the threshold, if the temperature is beyond a certain temperature. After that, we combine vulnerability. Vulnerability is very important. It's not, so the ways that heat waves affect people is different from place to place. So you need to know that all those different vulnerabilities are important for heat wave are factored in. So we combine all those, and we have what we call the heat map, and that's what we communicate. This is Senegal, and we communicate where are the potential things. But we do it really with the health services. So those are the vulnerabilities we identify when we discuss with professionals and to say really what really matters in terms when we have heat wave. For example, access to energy, because you know if you have air conditioning or not, or you are ventilated or not, access to water, vegetation cover, all those things are important, especially access to health care. So those are vulnerability we combine. So the way that it works is we develop the forecast, of course, and make it downscale or target over Senegal. So that's what we get by the Met Service. And the other environmental services will combine all those vulnerabilities that I show you in the maps, and then we combine the two, and we get a report or a bulletin of heat wave. So we know what heat wave is, and then we can develop a whole session now about the alert. Because it's very important also the next stage to ensure that the information is getting where it needs to be. So this is a technical bulletin. It's in French, sorry, but Senegal speak French. So you have 3 pages usually, that's what you limit it of. So the first page shows that really where do we have the heat waves this week, and and with the color code. And then we have the advice. This advice was developed by the public health because they know full well if you have heat waves, how it can impact population. So they developed this part. It's called produce bulletin, and then the type of populations that are really at risk, they put it here, and what to do. And then you have the risk map and all those advices you need to do. So this one was produced whenever we have heat wave. Whenever the forecast says that there is a likelihood to have heat wave, automatically the group met, produce this map, and make now the division. And the division is made, first of all, with all the hospital. District hospital in Senegal will get this bulletin through the health services. And also we make it public, and the decision makers, starting from the ministry and environmental, everything, everybody is getting this bulletin as well. So this is that we get. And then the dissemination channel, we use the Met service, what they already developed. We use different kind of, oh, it disappeared here, sorry. We use different kind of channel. Of course, we use community radio to ensure that this week is going to be heat wave, so such and such place. So people at remote area can get it. Of course, text messaging was the most powerful one because you send text messaging. But of course, one thing important is Africa, there are a lot of illiteracy, so people don't know how to read or write. So we develop kind of voice messaging. Voice messaging means that we record the message and then we send it, and people who are on the list will get the message, and when they pick up the message, start playing, and say, press 1 if you want to listen again, 2 to hang up. And then we can know exactly who get the message well, and who don't get it, we listen it with telephone, etc. So we also have communication with the national, TV, one of them. At least they will disseminate when we have heat wave. Of course, it's on internet, and there are many other WhatsApp group and other things that will ensure that they get this message. It's very important, this communication. And afterward, we also do some campaign, because assessing the fact is very important also to get a feedback to us as a community to use it. What we did is, once we discussed with community, went to the community, special community, discussed with them, all the stakeholders, women organization, community radio, farmers, people who deal with firefighters, hospitals, people who sell in the restaurants, public transportation, all those people who get together and explain to them, we have this bulletin, how it makes sense for you. What kind of information do you want to get? And what will change in your term of adapting on whatever? And they communicate. So we tailor the bulletin depending on the needs of the population, and then we disseminate it. We made the campaign, and then we get the information back. And here we was working really with Red Cross. Red Cross volunteer was going back, send the questionnaire and getting them back and tell us exactly what population get. So those are the volunteer that was trained before, in the questionnaire. They know how to put the questionnaire, how to ask the question, and who makes the sampling, what kind of population do we need to have the question, and they get it. And it was quite impactful, because that day we have the mayor of the city, we have also what we call the governor. The governor, as you know, is implemented. And then we have few impact. For example, at school, how Africa school are, how people learn. We got really feedback where some people fainted during that heat wave. And also we get the information that it's very difficult conditions that people are learning during heat wave. And even now, we are starting now contacting the education department, who was not part of this project in the beginning. In the beginning, we thought that people who are impacted are people who go to the hospital, pregnant women, children, people working outdoor. But we realize that most people who are impacted are children that go to school. And we realize even some places, children are working to go to get their lunch. They go to school at noon, they stop, and they have to walk sometimes 1-2 kilometers, go back to their home, get the lunch, and come back. And that was quite very difficult. So we really get some good feedback, really where to address our problems and how to tackle these things. Now, we want, of course, at AGMAT to upscale it, because heat wave is not district-wise. is comprised many countries, have no sort of boundary. So we have a bulletin that we are developing in ACMAT of heat wave, where we focus in whole Africa, where we have potential having heat wave, are highlighting it, and of course letting the countries implementing it. And now we are implementing more and more using different models, what we call multi-model ensemble, used and ensuring that we make a good focus of this and give it to countries, way before the heat wave happen. We also work through WMO in an effort where we could produce a global hydromet, we call hydromet bulletin. We ACMAT work in the African side. So we are the one who develops Africa here, and I acknowledge my colleague who is here, Godfrey, who are helping on that. And what we try to do is to look at not only heat wave, but any kind of, hazards, because, multi-hazard approach, and then flooding, heat wave, dust, whatever, heavy rain. We put all those things in a map and ensuring that people know what's happening. Of course, this map, the problem is really defining again the threshold. That's very important to know, And we work with humanitarian action to ensure that they get those maps. They know where in Africa we have problem and they can act accordingly. So what are the challenges and the way forward? Of course, it mentioned capacity building. Seems to us very, very important. Not capacity building generally or academically, but we think in order to advance it, we need to ensure that the community of health and the community of climate need to work together. So that's why at ACMAT, we have this, what we call on-the-job training, when we bring for each country a health and a public health expert and a climate, where they come, sit in ACMAT, discuss, and we show them few materials that we have so they can reproduce for the country. And we think that's very efficient. It's just targeting, trainings. That's very important. Evidence, research-based evidence is very important. There are a lot of things that is said sometimes in the disease related with climate, but there are not really strong evidence. So we think the research, the applied research is very important. Of course, ensuring that population know what's happening is also very important. And having also a co-production when we work with everybody. What I last say is climate change, as you know in the last report of IPCC, is projecting more extreme events. They're going to be more frequent and more intense. And Africa really cannot withstand all those extreme events. Our best approach, our best adaptation strategy to say is just anticipation. So that's why those things, early warning, preparedness are very important for Africa. So we need really, we are vulnerable, we don't have the means, we don't have the infrastructure. So our best approach is really anticipation. So that's why we are working with many partners to try to see how can we develop a best strategy of anticipating before the event occur. Thanks very much.
Thank you, Dr. Osmani. Very interesting and important presentation also. It's nice to see the operation, important to see the operational meteorological weather forecasting systems. And I must say that I stay a little positively impacted, mainly by the communication process, the society that you develop. Very nice, very important. And talking about this transfer of information, the communication, to attend health demands, I think that we can link with this phrase, the next presentation, our next speaker, Dr. Viviane Boaventura. I'm sorry, I must take my paper here. Viviane is a physician and a researcher at Fiocruz, Brazil. As the head of the Precision in Medicine and Public Health Laboratory at Fiocruz, Bahia, Dr. Viviane works to translate research into actionable health strategies. She also serves as a professor at the Federal University of Bahia Medical School and is an elected member of the Bahia State Academy of Science. Dr. Viviane, please, the floor is yours. Thanks for coming here.
Just inform me how to. Okay. So thank you so much. I think it's a very big responsibility to speak just after a lot of such amazing presentation. I was very inspired about the education and all the other topics that were discussed here. And I think this project will add a little bit and talk in some topics what you also just presented. So I will present to you the ESOP system. The ESOP system is the data-driven precision public health platform that we developed in Brazil for early outbreak detection. So I will briefly talk about what it is and how it works, and then talk a little bit about the performance in some surveillance situations that we had in Brazil, and also the application to support stakeholders. So we've been working for a long time analyzing that kind of administrative data for purpose of generating scientific evidence in several areas. And these evidences have been published in several good quality journals, which means that these type of data, administrative data, are quite important and interesting for other purposes such as surveillance. But adding surveillance in Brazil is pretty challenging, and we sometimes say that if we can do this in Brazil, we can do this anywhere, because it's a very complex country and very diverse. As you can see here, we have a lot of countries in just one. To take an example, in Bahia, for example, that is where ISOP state is coordinated, we have the same size as Kenya in Africa. So it's a pretty big country with more than 5,000 municipalities and a public health system that covers about 70% of the population. So the idea of ESOP is looking for syndromic surveillance, which means that instead of going directly to the etiology of the agent that is causing the outbreak, we look for this syndrome which make it feasible to be more, to do it earlier. So to take an example, for example, instead of looking for influenza or to COVID-19, we look for respiratory syndrome. And this ISOP that I represent here is about respiratory syndrome. So what we do is we take data about primary healthcare assistance, also OTC sale and rumors from social media, and analyze the longitudinal data that are generated by these sources to establish a threshold and to detect some warning signals. So in the end, moving from this sensitive profile, we go to a more specific one, looking to identify the cause of the outbreak. So in that part I will detail later. And also we look for monitoring the spread of the disease. As you know, by COVID-19, it's pretty easy to spread respiratory disease. And we do this by looking for climatological, socioeconomic, and also mobility data. So in resume, we want to act smart and early by leveraging these traditional and alternative data streams, act focused by combining the surveillance system with molecular approaches, and also act together all the time with the stakeholders. So you're going to see a lot of examples here, how we've been working with the Minister of Health to put these ESOP really on the hand. So the first data that we use is primary health care, but why primary health care? Because in Brazil we have a high coverage, and about 90% of these public units, primary health care units, have already the electronic health records. And so we can analyze this kind of data inefficiently and really cost reduction, because we don't have to generate the data. The data is already done for administrative purpose, that I said. So it's real-time responsiveness. The data is updated weekly. And another thing that we did is look at for creating a data quality index, because this data is not properly developed for this purpose. We had to see if it was suitable for epidemiologic surveillance. So, and how about OTC? OTC is over-the-counter sale. Basically, what we are thinking is that a lot of people, actually most people, instead of going to the physician, they first go to the pharmacy and get the drug to relieve their symptom. And I don't know if you know, if you're aware of this, but in most cases, this kind of data is already collected for commercial purpose. And what we are doing is assessing this data. It's basically in real time. They collect this data daily. And it's a relatively low cost because you don't have to create another data source. And it has a very good coverage, not only in Brazil. This company that's doing this work in Brazil, they're in more than 80 countries around the world. And this is very interesting because in a lot of countries that do not have primary healthcare data available, you can try to use this kind of OTC sale data for surveillance purpose. So this is just a quick example. I'm not going to stay on these graphics because it's going to get complex, but quickly, this is a manuscript that has been submitted. In blue, it's primary healthcare data. In green, OTC data. And later on, you can see that there is a peak in hospitalization, just demonstrating that this kind of data really can help us anticipate the increase in hospitalization. And we also observed that the better results are obtained when we combine OTC sale with PHC, but it can be used separately also. So how about implementing the system? So I will show quickly one example that we used in Brazil. This is the pilot that we ran in Amazon region last year. And just to pick up an example, I don't know if you're aware about the Parintins Festival that's very famous in Brazil. Parintins is a small city, as you can see here in this panel from the ISOP. So this is the dashboard. You can see here in green the areas that are without alert in primary healthcare. In yellow, they're kind of attention, and in red, if they need, there is a warning. And during Parintins Festival that occurs in epidemiologic week 26, we double the number of people in the city. So what we observed during the pilot is that in this area, the week before there was no case, Then during the week, no alert in this area, but around we had alert. And then a week later, we start looking here to see this small red circle. That means that the OTC data, the sales were increasing. So they're selling drugs for respiratory syndrome already in a larger amount compared to the previous one. So the other thing that is interesting is using this data, we are complementing the data in areas that we don't have a good data quality in this week, and we could observe that we have an alert here in the neighborhood of Parintins also. So this is the week later, going back. So as ISOP was able to anticipate in 3 to 4 weeks the traditional system of surveillance. Another example that we can use ISOP is to plan in advance some surveillance activities. For example, in COP30 that we occur in November in Belém, we look at in the last year in that area if we are expecting an increase in respiratory syndrome, and you can see here that actually there was a very good number of cases in this area during November, so we should be aware. Oh, sorry, I think I did something wrong. Can you it was completely me. It's the end of the day. I'm sorry. Everybody's tired, and then and also the computer. Can you help me?
Yes.
Yeah, it's going to be quickly. So, have to move? Okay, I'll go quickly. So, in the end, what we had is that for this example, it was very interesting to know that we should monitor respiratory syndrome before, during, and after COP30. The other application is, for example, for monitoring events like avian flu. We know that avian flu are areas that have birds, cattle, and birders are at increased risk, and we can just put them together and try to do a separate surveillance just to look if the number of cases are increasing. Of course, it's syndromic surveillance. We have to confirm if it's really avian flu, and for this purpose, we use this pathogen identification that is part of the ISOP. So we know that this kind of approach is very costly, and what we are trying to do is make it faster and more affordable. So we're developing strategies to do this feasible for a country like Brazil. This is so good. And the idea is to collect samples only in the areas that we have these alerts. and also do it by pooling samples. The other thing that we also did with ESOP is we analyzed the Sentinel surveillance network in Brazil. Currently, the Sentinel network, it's done by convenience. You can see in yellow in this map here, several areas that are in yellow are the current areas for this kind of surveillance. But what we observed is looking for the mobility, we should modify, not amplify, but modify these areas. And just doing this, we can amplify the coverage for 70% of the population. So it demonstrates how important it is to have a scientific-driven strategy to select these sentinel areas. So just next to finishing, I'll just concluding that part, we could anticipate in 2 to 3 weeks the syndromes. We also can optimize distribution of sentinel unities. We are already implementing the ISOP system with the Secretary of Health and Environmental Surveillance in Brazil. And also we are including some other syndromes like diarrhea and arbovirosis, which are very important in our countries that are low and middle income countries. So for arbovirus, quickly, we just published a paper demonstrating that using this kind of primary healthcare data, we could anticipate almost 70% of the regular surveillance system to detect outbreaks of arbovirosis. For the ones that are not aware, arbovirosis are those ones transmitted by vector bite, like dengue, chikungunya, Zika, and also Oropushi. This is a quick example of this year. A few weeks ago, we detected an outbreak in a city called Anastácio, that is here in Mato Grosso do Sul. The outbreak occurred in week 22. And in the same week, here in red, you can see the outbreak. And in the same week, we were able to go to the city. This is B, assisting the patients with the other healthcare workers. And this is the Secretary of Health of the municipality with us. We not only did this kind of confirmation, but we also had the opportunity to engage the population and to discuss problems and try to implement new strategies, and also capacity building with the medical professionals that were there. So it was a pretty nice experience, and demonstrating how good we can do surveillance can be like applied to the next step, not only being showing that there is a lot, but doing something more. So I think it's almost the end. This is the next week, just to say that you have to keep looking because other municipalities still had outbreaks following that one. And we are very glad that now ESOP is part of the action plan for arbovirus disease response of the Ministry of Health, thus just demonstrating how important it is to work closely with the stakeholders. And ESOP will remain data-driven and practical for surveillance teams. So this is some strains of the system. I will not read all of them, just highlight one here, that we are always combining sensitive data with specificity from molecular data. We also are doing everything that we are doing is published for free and open codes, which means that another country that is interested in that it can usually obtain this information. And for future development, I will highlight here the importance to expand to new pathogens and to expand to international settings as next step. So a kind of pandemic proof to do surveillance networks. In the future, we think that the surveillance will be much differentiated with new data coming from wearable biosensors, environmental genomic, and mobile diagnosis, and we can easily extend and incorporate ESOP, these new kind of data sources to ESOP. So in the end, we know that ESOP can also help to support the rapid evaluation of interventions such as vaccine development, therapeutic monitoring, and pathogen discovery. So this is public health actions more precise, more equitable, and more impactful. Thank you. This is our group. I have to say that our lead is Dr. Bahal, that couldn't come to the event, but it's a really fantastic guy, and he could put together people from different areas, such as UFRJ, from Luis Landau here, and the group of not only health, but also mathematics, and also several math areas in different areas here. Thank you so much.
They don't have a mic here. Are you here? There is a mic, please. A microphone. Thank you. Yes.
1, 2.
Hello, thank you. Okay, I think that I have just one question for each speaker, and I will, first of all, I'd like to thank for all of you for the presentations. It was amazing. It was amazing your presentation about ISOP. And I just want to ask for you just to try to be briefly, because we have audience that want to do some questions also. So let's go. I will start with Charles. Charles was an amazing a presentation of you, and to see the strategy and the framework of CDC to attend the demands of impact of climate change over health surveillance. And you said, you mentioned that things here in Africa are being most of the times proactive, as I understood, and not, sorry, must be reactive and not proactive. And what about the future, the perspective about this? You mentioned also some pillars, like capacity building, and funds, of course, is very important, and the integration of the different countries from the continent. What you can say about it?
Thank you very much. Yes. So futuristically, we're looking at changing the dynamics in terms of being reactive as against being proactive. And I think that is what the strategy is trying to drive. If you look at all of the presentations we've had so far, you've seen that we've incrementally begun to increase skills. Now, for us to be proactive, we need to have health workforce that anticipates. I think somebody talked about anticipation. And what we want to do is to be able to mainstream climate actions into health programming, starting with the fact that climate meteorological data should link with epidemiological data to inform a climate-smart early warning system. And I think what has been presented from Brazil, and just to say that Africa CDC, we're cooperating with Brazil. We've developed a joint action plan with Fiocruz around some of this thematic area. But one of the things we're trying to do is to see how can we're trying to also build a data center where we can mainstream meteorological data like what ACMAD is producing, what the GAD Climate Prediction and Application Center are producing, to see how we can sync it, and member states can actually pull from those databases to inform health action. So incrementally, we're building that strategic drive towards a more proactive surveillance system. But beyond that, we're also looking at how do we make the communities more resilient? What currently is the indigenous methods of anticipation? And that is where our risk communication and community engagement is actually focused. What is the current practice, and what do we need to do differently? So if it's just, of course, because of time, but if you unpack all of those strategic interventions, you see a lot of, we've identified key proactive actions in terms of communication messaging. What segment do we need to talk to about what? Okay, we need to also do a mapping of where are the most vulnerable communities, what are the practices that inform their vulnerability, and what can we do differently to be able to show that resilience. So maybe I'll just give those highlights. But beyond all of that, we're increasing partnership. So like I did say, a lot of activities were done siloed. Some of what ACMAD was doing before now we did not know. And then we've seen what CSIR is doing. So we're beginning to see how we can network researchers. We are beginning to define continental research agendas that are specific and strategic. And then very soon next week, later this month, we'll be having a Pan-African conference where we're trying to bring policymakers and researchers so that we're trying to see how we can enable research to link into policy, and how policy people can also inform the kind of research that researchers in Africa are undertaking. So those are some of the steps we're already taking now. Thank you.
Thank you, Dr. Charles. Sorry. It was obvious I think for everybody that communication is a theme that was transversal to each of presentation presented here today. And talking about that, Dr. Daniele, you mentioned that of course, the most important thing is to understand the climate change dynamics over health and transfer this information for the health professionals. But you have other features related with climate. For example, climate variability, El Niño, La Niña. These things, I know that is not your research area, but you can say something about that. For example, these aspects of the climate dynamics are also included in the formation of the health professionals that your project attends.
So we had a specific training on El Niño and the effects on the Latin American and how it impacts on agriculture and food security and how it will impact also in health. So we try to connect all this information. Of course, that our audience is more related to health professionals in general, but we try to make this connection on the direct impact of climate change on health and the indirect impact of climate change on health, and make people understand that they need to have some skills to prevent. At the end, what we are saying here, I think all of us together, we are trying to prevent the impact, and we are trying to anticipate, and we are trying not only to avoid mortality and morbidity, but we are trying to avoid the collapse of health systems, because we already know, we know that in many places, like in Africa and like in Brazil, the health system is already overburdened, and we need to help them to be prepared and also to better respond in a velocity with the capacity that it needs to have during these events and disaster, and also to prevent and inform people to participate and to know what to do in this case, so we can decrease their exposure of all this to all this impact, and in the same way we will decrease also their visit to the hospitals and etc. I don't know if I respond to your question.
Yes, yes. And other things also. Yeah. Dr. Osmani, very nice presentation also. As I said, I was very positively impacted by the communication with the people that really needs to understand the information, that the strategy that you developed is very interesting. And I'd like to know the sense of belief of climate change from the farmers, from the people that are in the extremity of they are the most vulnerable ones. No? What is the sense of belief in climate change? They really believe you have to do a basic work to them and explain to the farmer that what happens at the ocean, at the atmosphere, in other places impact in our daily life. How can you say, what you can say about it?
Yeah, communication is very difficult. I think it's the science itself. So sometimes we use social workers to do that. I was embarked in working with farmers and trying to communicate seasonal forecasting. And it's quite the same thing. You need some time to tell them, how the climate system works and how things are related. And usually by luck, if you use indigenous knowledge, sometimes that's the bridge really that you use, it make for them. For example, they will tell you in their stories that there are some animals they used to see, but now they disappear. Some trees they used to use in their medication, for example, they are disappear. So we take it from there and tell them, those trees need some certain condition of climate, and now this climate is changing. And they can tell you, of course, that yes, usually this period I used to sleep outside, but now I cannot do it because December is going to get colder. I mean, he says that sometimes the rainy season is starting, late than usual, and you can connect to that and make the connection with climate change. Yeah.
You offer also seasonal forecasts.
Yeah, we do a lot.
Nice.
Yeah, we do a lot.
Nice. Thank you very much.
No problem.
And Viviane, I stayed there in the beginning of the ESOP, in the very beginning of the project, and I went out of this initiative. I have some colleagues that are there working with you, and it's very nice to see what ESOP transformed in, and now to see that the health ministry in Brazil uses the system. And I'd like to know from you two questions. How challenging is to apply this surveillance system concept in a continental dimensional country as Brazil? And also, if you have, your group have any initiative or perspective of opening this dashboard in talking about communication to the civil society as a whole, in a communication that could be understandable by them.
Yeah, thank you for the questions. Just before answering, I would like to tell Daniele that I wish her educational platform was also available for stakeholders to make them understand the real impact in health. But they don't care, right? They don't use it. So the first question is regarding the implementation. So we are now facing the challenge. We did the pilot in Amazon. Now we are implementing in state by state. So it's a very challenging experience. We have a very diverse type of stakeholders. And if you go to small municipalities, it becomes more challenging. But that's this part of the job. So I have to say that every kind of information that we give is only for the Minister of Health, to Health Department, not for the municipalities. The ESOP was aimed to be used by the government, not by us. So we're gonna give them the system so they can run. And the idea with communication with the population is not giving the alert, but more about how to deal with this problem in terms of preventing and to also doing kind of diagnosing in a more popular way. So trying to help them manage and building capacities, as we just mentioned here.
Thank you. And I must say that, by the other hand, meteorologists, oceanographers, and climatologists must know health-based concepts also. It's not only in your direction. So now we're open for the audience. I think I have some minutes. Sorry, Dr. José Moutinho was the first one to I pass to you.
Can you listen? Can you listen to me here? Yeah. Okay, good. Just a quick question, Daniel. You provide some small grants, like $1,000, something like that. This was an award for the best projects, or it was the funding for the implementation?
It was a grant to all the participants to help them to implement their programs. So during this process, we work in many different topics, and they develop their curriculum, they develop their program, and they submit a proposal, but we already know that we are going to grant all of them. But the reason for the proposal is that we could work together and we could say, oh, this is not going to, maybe we can adjust here, this is not going to work, or maybe you can go to this way. And so we did this kind of assistance as well. And they all received this grant. It's a grant provided by Johnson & Johnson. and this grant is to help them to implement the program. Most of this program are inside of universities and also inside government, and so we hope that these would be a sustainable programs that can take like years going on and build the capacity of more people. And I think what we do is like we kind of trying to bring the science to these professionals so they can be able to translate this to the communities and to their patients, to their colleagues. And we also work with decision makers. We are now with a course for the whole Americas in scaling up adaptation on the climate and health in the health systems. And together with the Ministry of Health in Brazil, the Ministry of Health in Canada, the Health Canada, the Pan American Health Organization, the WHO, and other partners. And we also training the Andean region. We brought all the Ministry of Health, the Ministry of Environment, the Ministry of Agriculture, and after this course, they were able to build their national adaptation plan. So we try to address all the stakeholders related to health adaptation and resilient health system, and also mitigation. And so we work with government, we work with faculties, we work with students, we work with health professionals, and with communities as well.
Nice to know. Please present yourself and ask your question.
Okay, thank you. My name is Nuno Rahman, and I work at the Regional Center for Disaster Risk Management in Southern Africa. And it's not a question, in fact, it's a comment after hearing Dr. Viviane speaks, and not the presentation, but the comment that she just did, which is the platforms are open for stakeholders, but stakeholders just don't use it. And for the work that we do, it's very critical to understand why they don't use it. It's exactly what we do. We try to make the commitment between governments and communities that are part of the stakeholders. They are not all the stakeholders, but it's critical to understand why they don't use it, because there are a lot of money addressed to this type of actions, and a lot of thinking, a lot of science, and so why they don't use it. For us, it's critical to help in this communication process that we were speaking about. Thank you.
Do you want to say something?
No, I think it's perfect. The comment was about the Daniele's talk in education, but I think I completely agree.
It's not a simple bridge, it's a net. And all of the bridges must be constructed in order to have a real net. So, Dr. Paulo Gadelha, please.
I have questions for everybody, by the way. I really choose Viviane because of the time. The health issue is very complex, and you have different sources of data collecting, information, prediction, and so forth. There's a big challenge, and I'd like to know from the perspective of Israel, especially from the health ministry, how are these different approaches being integrated? And I mentioned not only what SIDAX and ZOP is doing, but in the case of another very important project of Fiocruz, which is the CGEL, that you know very well, that also deals with the question of zoonosis, and also from the perspective of the popular vigilance in health. Because when you have this data, somehow this data must be integrated, not only as support for other possibilities of data approach, but also how the community not only being communicated or taken care of, but deal with these data in a way that they are more effective in terms of community agency. Could you comment on this, or is it too complicated?
Yes, pretty complicated, but just to inform, we are not working directly informing the population because we think that there are some kind of sensitive data that we should take care. For example, if it's a huge in the number of cases, it could give an alert, and in the end, I think the authorities must be the first one to deal with this and then communicate the risk properly. So we know that there's a lot of misinformation and things that we have to think before thinking about giving these kind of, opening this kind of platform for the population. But I'm completely sure that we should work with education in this population to make them able to lead with this situation while they have the alert done. The experience that we have recently in Mato Grosso do Sul was pretty emblematic because it was, we came after the outbreak. We just did it during the outbreak, and then we came after, and we saw that a lot of things that we already trained people were like going back again. And it's clearly something that should be in process and be running like, not, we go there, you get the information, you train them, then you have to come back and do the same thing and try to evaluate. I think the word is evaluate, which was really implemented, and not only give the training and then go ahead and it takes me. I'm not sure if I answered your question because it was quite big.
Okay. We'll talk later.
There's a, please present yourself and do your question.
Okay, can you hear me? Yeah. Okay. My name is Tatiana Marrufo from the National Public Health Institute in Mozambique. I would like to congratulate all the presenters for the brilliant presentations. Thank you for that. I want to come back to Dr. Viviane. I was amazed about this system, this syndromic surveillance system. We are trying to implement something on respiratory diseases in Mozambique. It's hospital-based, but I was amazed about the triangulation between the data coming from the primary health care and also using data from the pharmacies and rumors. I'm not sure if I understand correctly. Can you develop a little bit more about how the rumors are integrated in this system? I don't think that I understand correctly, but I think I have a lot to learn as a country from what you're doing and even integrated in the health system in Brazil. It's amazing. Thank you.
I didn't have time to give the details, but what we did in the beginning is use the platform that's used to be the Twitter one. It was available for free, the data, so we used it kind of, I just forgot the name in the computer, but it's when you get the words from it's a strategy, you catch the words from the internet and then no, it's not the keywords, but there is a specific name that they do. So the computer learns how to do this, and they do it automatically, getting this kind of, for example, flu or headache or fever. It's kind of machine learning, but there is a specific name I forgot now. So because they take from long tests, and then they select these words, and this is the way we got the information. So in the end, Twitter was sealed, as everybody knows, and we lost this. To have this kind of information, you have to pay a lot, and we don't have this condition. It's not feasible to apply this in long term, so it's not our interest. And we are now using rumors that came from official channels, not only in Brazil, but outside Brazil, and that goes, for example, from journals or in media in general, not only in internet. We really want to have more, but we are still like walking in this area. It's not that advanced as is for OTC data in primary healthcare. So by now, what we do is we're trying to like confirm the data that we receive with OTC in primary healthcare to see if it's matches or no. But the main warning comes from OTC and primary healthcare. And I will be glad to talk with you later and then try to exchange experience.
That's why G-STIC happens. Nice. So that we are over time. Had already, I don't know if you want. I know that Paulo wants to do other questions. As the
We don't have time, do we? We don't have time.
No, we don't have more time.
Okay.
It's already finished. But as you're going to stay here for the gala. But okay. So I'd like to thank everyone, each speaker for the participation in this deep dive. It was very interesting. I learned too much with you. And thanks for the audiences to be here until now.